Hi, this is Colin Barker from Vanderbilt University Medical Center, where I'm Associate Professor of Medicine, Director of Interventional Cardiology in the Cardiac Cath Lab, as well as Program Director for the Interventional Cardiology Fellowship. And I'm grateful to be able to present a case for the Cardiovascular Innovations 2020 digital meeting regarding prosthesis regret. This is a case of a 56-year-old female with a history of aortic stenosis, who in 2012 had an aortic valve replacement with a bioprosthetic 21 millimeter stentless 3F valve, as well as mitral regurgitation, and at the time had concomitant repair, hypertension, hyperlipidemia, chronic stage 4 kidney disease, and multiple comorbidities, who had had multiple admissions over the past 6 months with decompensated heart failure. Was seen and evaluated by surgery multiple times, and she adamantly refused another open heart surgery, and surgery admitted that she was relatively high risk given her comorbidities as well as relative immobility due to degenerative joint disease in both knees. Here is the op note from 2012 illustrating, documenting the aortic valve replacement with the 21 millimeter 3F valve, a repair with a 63 millimeter band, concomitant PFO closure. During the time, there was a perforation of the coronary sinus that was repaired, and mention of really abnormal double barrel left and right coronaries coming off essentially from the left coronary sinus. Her most recent echo, which was in October of last year, showed severe bioprosthetic stenosis with limited mobility of at least one of the leaflets. Her mean gradient was up to 56 with a DOI of 0.25 and an aortic velocity of 4.7 meters per second squared. Postoperatively, she had high-ish gradients in the low 20s, but this was a significant jump from her postoperative hemodynamics. And here's a two-dimensional echo showing the leaflets and the immobility of the leaflets on the left, and the Doppler velocities on the right across the aortic valve, showing some of the velocities getting as high as 5 meters per second. In order to evaluate her for TAVR, she underwent CTA, TAVR protocol planning. The annular measurements beyond the distal portion of the valve showed a perimeter of 78 millimeters with an area of 484 millimeters squared, and a derived diameter of anywhere from 24 to 25 millimeters. Her sinuses, however, were on the smaller side, and she essentially had significant calcification of all three of the bioprosthetic leaflets. The 3F valve is just shown to have an internal diameter of about 20 millimeters and a height of the leaflets of about 25 millimeters. So the challenge here, which can be seen here, is that both the left coronary artery and the right coronary artery do originate from the same sinus of Valsalva cusp, specifically the left coronary cusp. And in addition to coming off the same cusp, the distance between the left coronary artery and the right coronary artery and the valve plane is very small, less than 4 millimeters, anywhere from 2.5 to 3 millimeters. So the challenge here is going to be coronary occlusion with a transcatheter aortic valve replacement. We decided, based on the sizing from the manufacturer, to go with a smaller valve with a 26 millimeter self-expanding valve. We had toyed with a bigger valve, but we thought 26 will give us decent hemodynamics, maybe minimize the risk of coronary obstruction or occlusion, and essentially fix the bioprosthetic stenosis. So in order to make this procedure potentially a little safe, we employed two techniques. One was a Basilica of the left coronary cusp leaflet of the bioprosthetic valve, which is seen here on transesophageal echo on the left and fluoroscopy on the right. You can see on fluoroscopy we have both catheters engaged with the snared Estado wire with the flying V, and we apply electric cautery and lacerate the leaflet. We also employed the technique of having a stent down in the left coronary artery if we needed to bail out and reperfuse, or if there was some signs of obstruction. So here's the post leaflet laceration transesophageal echocardiogram showing significant aortic insufficiency as a result of our Basilica procedure. And here is a post-valve deployment angiogram with the stent still in place but not deployed, but good coronary flow and what appeared to us to be a decent amount of space between the valve and the ostium of the coronary artery. However, we were discouraged by the residual high gradient across the valve and valve, measuring anywhere from 30 to 40 millimeters of mercury mean gradient. So we decided to proceed with post-dilatation. And before we did that, since we were fairly comfortable, and this is the main learning point for us from this case, we removed the guide catheter as well as the undeployed stent and coronary wire, then proceeded with rapid ventricular pacing and post-dilatation. You can see there was still significant residual stenosis there in the inflow that we were able to treat with high pressure balloon inflation with a 24 millimeter true non-compliant balloon to high atmospheres. And the hemodynamics really improved significantly with almost no gradient now across the aortic valve. So we started to complete the case and remove catheters, and anesthesia was starting to scurry around, and you noticed something was going on. They were having trouble suddenly with their blood pressure. We hadn't removed the large sheets yet. Put the TE probe back in, and on the left you can see sort of global hypokinesis, and there's a little bit of a time lapse between these two, and on the right you can see essentially cardiac standstill, and at this point in time we had put the patient on emergent peripheral VA ECMO. And what had resulted is complete coronary occlusion, and remember both her right and left coronary arteries originated from the left coronary sinus. So after resuscitation with CPR, eCPR, ECMO, VA ECMO, and left ventricular venting with a Impella CP, we had a quick in-room multidisciplinary discussion about emergent bypass versus proceeding with an attempt at revascularization of what was now an occluded entire coronary circulation. And it was deemed, again, since she really wasn't a surgical candidate prior to this in a more stable situation, she was now even more prohibitive for surgery. So we proceeded to attempt to revascularize her. And what you can see on the left is the only thing we could get down initially was an 035 glide wire. We had to probe pretty aggressively through the both the leaflets, the bioprosthetic valve leaflets, as well as the new valve platform in order to get anything into her coronary. We used that as a rail to bring up a second guide. We were able to get coronary wires down and then subsequently snorkel a large 4.5 millimeter by 32 millimeter drug-eluting stent. And the result on the right, you can see we were able to reperfuse her successfully, and you can appreciate, obviously, the stent was going into the left coronary, but in so doing, we were able to open up the anomalous right coronary artery coming off the left coronary sinus as well. And so once we did that, we were actually able to wean down some of the support. Her left ventricular already immediately began to recover, and we were able to get her out to the ICU. So this is her TEE, which was done 3 weeks post-TAVR, which shows really complete resolution of any left ventricular function. The bioprosthetic self-expanding valve and valve is performing well without significant insufficiency or stenosis. Unfortunately, she had a fairly prolonged hospital course and ultimately expired. On day 3, both the Impella and the ECMO were explanted, and a balloon pump was placed for minimal residual support. The balloon pump was subsequently removed, and she was extubated a week after the procedure. And a few days later, she was transferred to the step down and ultimately to the floor. Her course was really complicated due to recurrent and sort of refractory wound infections that required extensive debridement and flaps and multiple trips back and forth to the OR, where she finally sort of had enough. And this was in peak sort of COVID era. And she and her family requested to be transitioned to palliative care and hospice. And on day 75, after the TAVR, she subsequently expired. So I think there are several learning points here. One, moving forward, we've decided if there's any thought that we may need a stent to snorkel and provide perfusion to the coronaries, we're going to keep it in place for any manipulation, post-dilatation, valve-in-valve, whatever, where there's risk of obstruction. Therefore, we would have had an immediate bailout option here rather than having to go on bypass and do this under a much more high-risk environment. The second part of that is now we've had a few patients that we've had to emergently put on ECMO because of coronary occlusion. And, unfortunately, this lady expired, granted 2.5 months later, but our 2 other cases we've done recently, the patients have survived and discharged and are now being followed in the clinic. And really, I think the only way we got them out of trouble was a multidisciplinary team present, able to activate and put people on ECMO emergently with some sort of left ventricular support, and then subsequent aggressive revascularization. And this was entirely a team effort with interventional cardiology, cardiac surgery, cardiac anesthesia, interventional imaging, and really exceptional staff, nursing support, technicians, who were all in 100% to get through this. There were multiple times you can imagine during a case like this where you think about throwing in the towel. This was about a 6 or 7 hour procedure. And I don't think anyone regrets the effort we put in. Again, though, I think the learning points were specifically, if the stent's there, leave it until you're completely done with your procedure, especially if you're going to post-dilate, and also having access and resources to put people on emergent, aggressive, almost full support. And with that, I will thank you for your time.